My name is Dr. Sharma. I'm a consultant neonatologist. I'm currently working at the Cornish Hospital, and we are currently running our annual lung ultrasound course, which is an online course, which basically has 35 participants. Uh, Today, we have colleagues from the old batch as well. So I think we'll have a much larger group. I'd like to welcome you all. But what I'm going to do is I'm going to spend about an hour talking to you a little bit about the problems with differentiating consolidation atelectasis and really how and when we suspect that we might actually have a mnemonic kind of a presentation. So I'm just going to start by sharing my screen so that it's visible. Dr. Ashraf, you can see the screen?
Yes, I can see it.
Lovely, fantastic. So I'm going to make a start. So I'm going to start by saying that actually we've just in the process of publishing a piece of work that I'm doing with Dr. Pradeep Suryavanshi, who presented on pneumonia last week. And really what it does is it looks at 176 colleagues who've been trained over the past 4 years in lung ultrasound. And we've taken their kind of a qualitative analysis of their views on the learning curve with the different pathologies that we have, the opportunity to diagnose using lung ultrasound. And interestingly, whilst RDS and TTN is something that they found relatively easy in the learning curve. So the majority of people feel that by 3 to 6 months, they feel relatively confident in making a diagnosis. When we start talking about consolidation, atelectasis, and pneumonia, it becomes a little bit more complicated. And fewer people were confident at 6 months in trying to make, and differentiate between these entities. Now, the reason this is very important, I would say, is because there are therapeutic implications for the diagnosis. It's really important that we consider clinical correlation in this process. And really, what I'm going to do is I'm going to start with a little bit of revision for both groups because we have the old group today. But whenever we talk about lung ultrasound and the normal lung, really what we're trying to do is we're trying to identify what is classically called the batwing sign. And really, if you look at lung ultrasound in the diagnosis of neonatal lung disease, in the normal lung, you've basically got ribs. So these are ribs, as you can see over here, followed by a very bright pleural line. Now, naturally, because rib is bone and the pleural line has an interface with air beneath it, they're very good reflectors. And as you can see on this particular image, the ribs appear bright. Naturally, because it's bone, a very little ultrasound wave can actually penetrate through, and you've got this kind of area of what we call as acoustic shadowing behind the rib. But below the level of the pleura, what we basically see is artifact. And really, this appearance that you see is basically called a batwing sign. Now, theoretically, it doesn't resemble a bat in my opinion at all. But the reason it's been named so is because bats communicate using ultrasound. But if you want to identify and classify lung as being normal, really what you want to be able to see is the normal batwing sign with what are parallel A lines that I'll show you, but with an appearance that gives you a classical seashore sign on M mode. And if you can identify this in all the lung regions, then really what we're dealing with is normal lung. So again, this is normal lung with lung sliding. So you can see ribs over here at this particular point with pleura that's sliding, and you have these parallel horizontal kind of lines that become a little bit less bright as you move down. These are classical A lines. Now, this is uh, an adolescent who's breathing very slowly, but what you can see is the sliding with a few comet tails. I mean, this in a sense is normal lung. But with normal lung, what is very, very important is you need to be able to identify sliding. And at any point, if you're not able to identify sliding, then there is a problem. And there could be a number of reasons why, but a common reason why you might not have lung sliding is because you have air between the visceral and parietal pleural interface. Now, whilst it will also give you A lines in parallel, the absence of sliding in this particular situation could be indicative of a pneumothorax. Now, the reason I am revising and talking about this is because really when we talk about the normal lung and the abnormal lung, what we should be trying to do as a group of individuals is really trying from our perspective to be able to communicate in the same language. And I cannot emphasize this enough. So if you are doing lung ultrasound and if you have not got a guideline which talks about how you are going to describe the lung appearances, but more importantly, how you're going to report them, then really there's a risk that you'll have non-uniform reporting practice. And I think that can make things very confusing, especially when you have to follow things up. But a very good nomenclature has been developed by Daniel Lichtenstein, which has been published in his book, Lung Ultrasound in the Critically Ill. And really, what it talks about is being able to recognize profiles. Because actually, if you're able to recognize profiles and you use the same terminology, then really, from our perspective, it's quite beneficial in being able to communicate that to each other as a descriptive methodology of what you can see on the lung ultrasound. But more importantly, when you actually report it, it just means that you're using the same language, especially if you plan to do serial lung ultrasounds. Now, whilst these profiles have been applied to adults, just going through the basics, we've extrapolated them to actually describe similar kinds of appearances, pattern recognition in neonates. And an A profile with lung sliding is essentially normal lung. But what we must represent in our thoughts is the fact that a baby who has been born at birth may well have interstitial fluid, and he may well have a B profile, which transitions to an A profile. Now, that does not in itself mean that we're dealing with pathology. This could just be normal transition. And that's why I would say it's really important that you standardize how you're describing the lung. But we're just going to talk about the different lung profiles in the next few slides to try and give you a little bit of an overview of what they represent before going into consolidation. So in essence, an A profile is a normal lung profile, which basically has pleura at the top with sliding with parallel A lines. So this is classically normal aerated lung. A B profile, however, has pleural lines with these vertical uh, reverberation artifacts, which we call B lines. And really, once you start seeing a B profile, or I would say uh, a kind of a whiteout kind of an appearance with abnormalities of the pleura, we usually call that a C profile. And that is usually how we describe consolidation. And use a similar kind of a definition to kind of describe atelectasis as well. More importantly, from our perspectives, by using these standardized terminologies, whenever we say A, B, and C profile, we always assume that the pleura is sliding. On the other hand, if you find that the pleura is not sliding, we tend to use what we call our A prime, B prime, and C prime profiles. And an A prime profile, as I've classically described, is seen in a pneumothorax. We'll talk about the B prime and C prime profiles. These are just examples of an A profile. So this is a classical A profile for you. You can see pleural sliding with parallel A lines, which are equidistant. This is normal aerated lung. This is using a sector probe. Uh, Naturally, if you're using a different kind of a probe, like a curvilinear probe, and this is technically a head scan probe, you can see the differences in that the pleura and the footprint is quite small, but you have a very similar kind of an appearances. And both of them will represent good lung aeration. Now, as I've described in neonates, it's very important from our perspective if at birth we're trying to describe the lung, that we talk about B lines because B lines can be present. And if you have less than 3 B lines per intercostal space, then from our perspective, this is still normal aerated lung for you. And we would still call this an A profile. On the other hand, once we have more than 3 B lines per intercostal space, we transition into a B profile. And if you look at the different kinds of B profile, you can have classical appearance here where you've got ribs, one intercostal space with pleura, and more than 3 B lines per intercostal space. So you're kind of in the situation where this is now progressing to more than 3 B lines. This is less than 3 B lines to more than 3 B lines. But these B lines, as fluid increases in interstitial space, produces what we call as these kind of horizontal artifacts, which are coalesced B lines. And they're called compact B lines. They're kind of like big quadrilaterals. These are gradually progressing to the point where you get a complete whiteout. And this is what we call as alveolar interstitial syndrome. This is kind of a white lung, and really this is dense white lung for you. You can't see any A lines in this. So when B lines are present and you have a classical B profile, really the A lines get obliterated. And this is how B lines in a B profile progresses as alveolar fluid and interstitial fluid increase. In babies who are transitioning, naturally you'll have aeration side by side with fluid. So classically, the description of transient tachypnea is a baby who's gradually aerating lungs because he's breathing the fluids getting absorbed. So often you'll have an A well aerated profile next to a B profile. Now, this is classically described as a double lung point, but more importantly, from our perspective, some people have used the terminology AB profile. We're tending to move away from this because Daniel Lichtenstein uses this in a completely different context. But this is classical transitioning lung for you. What we are going to talk about today, after this small revision in the first 10 minutes, is really what we call as a C profile, is really what we call as lung consolidation profile. Now, lung consolidation profile has four features. You will have pleural abnormalities. You will always have abnormalities that arise from the pleural line. So if you see this area here, it's quite dense. You can not see any A lines. And really what you see is a B profile with what is more or less, I'd say, alveolar interstitial edema. But this area here looks very irregular, patchy, with a few static air bronchograms. So classically, pleural abnormalities with a B profile, with or without sliding, uh, with or without certain abnormalities that I will describe. And this C profile basically represents a consolidation profile and can occur for a variety of reasons, which could be RDS, could be meconium aspiration, could be an infective pneumonic pathology, or could be a simple consolidation collapse because you've got a tube down the right main bronchus. So clinical correlation is very clear. This is just another example of what we call an A prime profile, which is a pneumothorax. So again, in this, you will not be able to see any lung sliding. You see classical A lines at the bottom with what is classically described as a truck sign. And this is a mirror image of the overlying rib shadows because there is air between the visceral and parietal pleura, which is an excellent reflector. So you have mirror image artifact. Uh, just always remember, there is no lung sliding and a lung pulse is absent. So this is what we call as a classical B dash profile. And again, some people would like to call this a C dash profile as well, but you've got a B-lyse interface over here where you've got alveolar interstitial edema and the pleura is not really moving very well. So, some people like to call this a B prime or a B dash profile. Now, a very important aspect of trying to recognize consolidation, and when we talk about atelectasis, is lung pulse. And really what it emphasizes is that we normally see sliding. So really what you're seeing at this particular point is sliding in this particular region over here. And sliding basically means that the visceral and parietal pleura are moving over each other. Now, if you have significant areas of lung that are not aerated because air can't enter them, or because exudate is blocking that particular bronchus, then really what happens is you will not have aeration to the point where you can actually have the visceral and parietal pleura slide over each other. And really, what you then see is transmission of cardiac impulses. So if you look at this image over here, really, you're not seeing any sliding here. What you're seeing is this kind of bounce. This is classically lung pulse, and it basically reflects a reflection of the pleural line uh, affected by what I would say is cardiac impulse or cardiac pulsations. Again, from our perspective, really what you would see when you do M mode is these small areas of bobbing that we classically call T lines or transmitted heartbeat pulses. Now, if you have this kind of an appearance, this is lung pulse. Uh, this is just an example of how you differentiate lung pulse and lung sliding. So in the slide below, you can see classical lung sliding. But in the slide above, you can see classically what we call as lung pulse. So this is pleura moving horizontally, visceral and parietal pleura, whereas this is kind of just a little bit of a bounce. Just gonna show you this to you again. So in this particular image, you can see sliding on your left-hand side, but on the right-hand side over here, you've got a large area of consolidated lung. You cannot see, you can just about see a very abnormal pleural line. What is a tissue sign? And this is classically what we see is a lung pulse that's being transmitted because there's a lack of aeration in this particular region of the lung. So it's a classical C profile. I'm just gonna finish by saying that actually it's important for us to use the same language. And really, if you've not already got a protocol which tries to define how you're going to report and pattern identify different kinds of normal and abnormal states of the lung, I think you should really work on it. Now, I'm going to start now for the next 45 minutes talking about lung consolidation, atelectasis, and really how we diagnose pneumonia. But just before I do that, I would like to talk about why we see the findings we see on lung ultrasound when we talk about consolidation. And really, what you must remember is that when you talk about a classical A profile, as you can see over here in this image, this is aerated lung. So the pleura basically is moving on itself because you've got air in this particular part of the lung, which is aerating right up to the pleural margin, and the visceral and parietal pleura are moving on itself. But if for any reason the bronchioles or you have an area of fluid or exudate that enters into those bronchiolar spaces or the alveoli, then you will not have air enter it. And for that very reason, you may not have aeration. More importantly, because air is not entering that particular area, you have fluid in it. It will act as a good reflector. And really, what it will give you is a tissue-like appearance that you see over here. So a very tissue-like appearance, lack of aeration. The pleural line, depending on whether you have aeration or not, will may or may not slide. But in some cases, if there's complete lack of aeration, it may not be easily visible. Now, classically, from our perspective, this is why it happens. And it's because you've got bronchiolar obstruction in a mnemonic kind of a presentation. You might have exudate blocking this bronchus, which means air cannot actually enter into it. But more importantly, you might actually have a destruction of the interlobular septa because of exudate, which eventually means that you've got fluid and exudate in this region, again, which technically, from our perspective, will give us a kind of a tissue-like appearance that we see in the liver. When we talk about consolidation, let's keep it simple. The idea about us making a diagnosis on lung ultrasound is about keeping it simple. And simplicity basically means that really what we're looking for is an abnormality at the level of the pleural line, which resembles either some irregularity, thickening. If you have a pneumonia, it could be very, very irregular. This is just a tube down the right main bronchus with, I would say, a little bit of alveolar airspace loss. You might actually not have irregularity. You might just have, blurring of the pleural line. On the other hand, with RDS, say, for example, you can have significant thickening of the pleura. With chronic lung disease and meconium, again, you can have pleural abnormalities that make the pleura thick. But more importantly, what you get when you have a focal area of consolidation or a consolidation is this kind of dense tissue-like appearance. And this is called hepatization. I will talk about air and fluid bronchograms as well as the shred sign going forward. But these are just examples of lung consolidation that you can see. So on the left side, what you can see in this region as you move forwards is a pleura that's quite abnormal, that's just starting to look irregular, with a coalescent B profile that's breaking your B lines. Now, this is a B profile and it involves a significant area of lung. But at this particular point, because we're looking at just one intercostal space, we don't know how large it is. Now, newer ultrasound machines allow us to look anatomically at very large areas of lung. And if you look at the right side here, you've got an area of lung that is aerated. So this is aerated lung that you see over here with an A profile, but then you've got this large area that looks like liver, which basically has no pleural line. And this is what we would call a large collapse consolidation. So there's an element of consolidation with atelectasis here with no pleural line. And really, this is the right lateral lobe. It's a large lobe. And this is classically what we call a translobar consolidation. It is seen in a variety of conditions. You might have a tube down the right main bronchus, which is giving you this appearance. It may be seen in mnemonic consolidation. It may be seen if you have significant atelectasis in babies with severe chronic lung disease. So what we're really describing is a pleural line abnormality, tissue that looks hepatized, and really the presence of air or fluid bronchograms that I will talk about. Now, this is classically a consolidation that you see in a neonate. So again, you have ribs over here with acoustic shadowing of the ribs. You have a pleural line, and you can see how thick and abnormal the pleural line looks, especially in this particular region. It's quite abnormal. You have inspiration, expiration, and really what is happening is you have this area that looks very tissue-like with these small pinpoint areas. And these pinpoint areas are basically trapped air. These are static air bronchograms. This is a baby who basically has a tube down the right main bronchus with a significant increase in oxygenation. Now, he's an extremely preterm baby who had surfactant where the FiO2 didn't come down. So really the question I'm asking is, most babies will have a good response to surfactant with an improvement in FiO2, but when we admitted this baby to the neonatal unit, this baby was still in 60-70% FiO2. And as soon as we did a lung ultrasound, what we realized is that we've got this right-sided consolidation. So we went back to looking at the tube, and for a baby who was about 800 grams, the tube was about 7, which is low. You pull the tube back and actually you can recruit this area of lung. But this is classically what you call a consolidation secondary to a tube down the right main bronchus. These are just examples of what tissue hepatization looks like in translobar consolidation. So on the right side here, you've got the liver. The liver has some blood vessels in it, but this is a large translobar consolidation, which has a very tissue-like appearance with small static air bronchograms inside. Uh, you can see how this tissue-like appearance can have a varying appearance depending on the ultrasound machine that you're using. So it may not entirely look like liver, but it will give you quite a dense appearance. And if you can see a pleural line abnormality with such an appearance with static air bronchograms and a B profile, then really from our perspective, you're dealing with what might be a consolidation. Daniel Lichtenstein basically talks about consolidation in different kind of ways, but what he's classically described as the tissue-like appearance of the liver. Now, this is liver, and this is basically the lower lobe of the lung in R1. So you can see how similar they actually look when the tissue becomes hepatized. What is very important from our perspective is that we do not confuse lung consolidation with the thymus. Now, this is the thymus that you see over here, and you can see it both on the right and the left sides, especially in the right upper and the left upper regions. Sometimes it's large enough to actually encroach upon the right middle, and I would say, even the left lateral regions. So this can give you a very tissue-like appearance. There's a vessel that goes through it. It's usually got a capsule to it. And I would say you need to be very cautious about how you interpret this, because somebody might think that's a right upper lobe consolidation. It's not. But if you look to the right of it, you can see pleura that looks thick and blurred with what is a very dense B profile. With the eye of faith, because I'm using, and this is just a good example of very poor image quality. The gain settings are very high, so you can't actually see the static air bronchograms. But this is a consolidation, and this is a baby who basically had a right-sided upper lobe consolidation, where one of my trainees was doing the scan and felt that this is actually atelectasis. It's not, it's thymus. But this is a significant consolidation. And with time, this was right upper lobe. So it's just an example of what a translobar consolidation might look like in a neonate. Now, a very, very important aspect of consolidations is what I've shown you so far is consolidations that look very defined, very regular, with kind of hepatization. But you may see areas of shred of fractal sign, what is classically described as a non-lobar consolidation. So a good example from our perspective is this image over here. This is a neonate who was unwell with a high CRP with respiratory signs and symptoms. And just in the middle over here, you can see this area that basically looks very irregular. you've got an abnormal pleural line here. There is pleural sliding with a B profile in the rest of the lung, but then these areas of what we call a bright pinpoint trapped air. This is an entire consolidation, but with very irregular margins. This is a very subtle fractal sign for you, and it basically indicates that the pleural area, the area of the consolidation, the margins are very irregular. Now, if you see this, this can be a marker of infection if you clinically correlate. And this baby, incidentally, ET secretions cultured had evidence of Pseudomonas on the actual ET secretions with a high CRP. It was also very patchy. But just to remember that a fractal sign, as we describe it, or a shred sign, as it's commonly called, can also be seen in meconium aspiration. It can also be seen after a pulmonary hemorrhage. And it can be seen if you have significant lung damage, in evolving chronic lung disease. So it's not pathognomonic of infective process, but its presence should always make one have an index of suspicion that infection may be lurking in the background. This is a really classical example on the right-hand side of a large area of consolidation with very irregular margins. So you can see here the irregularity, the consolidation, and this is classically what Daniel Lichtenstein describes as a shred sign. This is just the same image magnified. And again, what you can see over here is an area of irregularity this is a very subtle shred sign. The reason I'm showing this to you is it can be easily missed. So this is very obvious shred sign that you see over here, but it can be very subtle. And it's really important that you interrogate your lungs. Like if you're doing a comprehensive scan, that you interrogate your lung fields very carefully because it can be very subtle for you to see. It can also be very severe. Now, this is basically an image from pediatric emergency medicine for a child who has got a significant translobar pneumonia. And what you can see as you move from up to down, this is a very advanced ultrasound machine, which basically allows us to be able to see the lungs in 3 dimensions from top to bottom. So the upper lobe, as you see on the left-hand side as you move down, is actually normal and well aerated. But as you move down to this region, there is extensive consolidation with a synemonic effusion. You can see over here, there's compressive atelectasis at the lower lobe, but you've got this massive area shred sign. And really what this is this is dual pathology. You have consolidation with shred sign with atelectasis with a synemonic effusion. And this is really a whole lobe of the lung which is gone. I mean, this is very suggestive of an infective process at this particular point. What are air bronchograms and why are they important for us? Now, air bronchograms have been described on chest x-rays, as we know, and they basically reflect areas of air that are trapped within the bronchioles, the bronchiolar tree, which basically highlight when you have an element of consolidated lung, as you might see with RDS on a chest x-ray. Actually, you can see them on ultrasound as well. And if you're able to differentiate static from dynamic air bronchograms, then that can be a significant pointer towards certain pathologies. In particular, dynamic air bronchograms tend to be found with mnemonic kind of presentation. I'll explain why. Static air bronchograms tend to be seen with consolidation. They can be seen with atelectasis, and we see them in RDS and MAS. But dynamic bronchograms tend to have, I'd say a very high index. They should make you think with a very high index of suspicion that there might be an infective process going around in the background. Air bronchograms tend to appear as hyperechoic. You remember air is a very good reflector. Because it's a very good reflector, there'll be a significant difference in acoustic impedance causing reflection of sound waves. So air bronchograms tend to be bright, dense, speckled. They can give you a snowflake appearance, as we might sometimes see with RDS. On the other hand, if you have fluid, we know that fluid is a good conductor and the acoustic impedance is a little bit less, so it allows kind of ultrasound waves to go through. So fluid bronchograms tend to be hypoechoic and appear dark. The presence of fluid in the lungs, and in particular dynamic fluid bronchograms, usually indicates that you have exudate of some kind in the bronchial tree. And again, highly correlative of the presence of pneumonia. If you look at the literature, J. Lu has done a lot of work on the description of pneumonia, and it's articles that I will share with the group today. But really, if you look at alveolar consolidation, if you have the presence of tissue sign, kind of hepatization along with a shred sign, the certainty of you having an alveolar consolidation is very, very high, as well as the specificity. Uh, there are definite areas of alveolar consolidation that you might be able to pick up on lung ultrasound, which you will not be able to see on chest X-ray. So ultrasound is a very sensitive way of at looking at this. Now, these are just examples to differentiate static and dynamic air bronchograms. Now, this is just another example of a baby who has a tube down the right main bronchus. And this is lung atelectasis for you. This is not entirely consolidation. And when I explain it to you, I will say to you that this kind of concept that we should differentiate consolidation atelectasis as being pure forms is flawed. Often consolidation and atelectasis coexist. But classically in this particular region, what you can see on the right-hand side is pleura. You can see B lines with some, I would say, comet tails. The image quality is poor because of the high gain, but these are actually A lines. But in this right upper region at this particular point, there is no pleura. There are these pinpoint bright areas, which are basically static air bronchograms with an area that actually looks hepatized. Uh, because you have no pleura at this particular point, the real question is, well, this could be consolidation. Is it atelectasis or not? Now, in this particular baby, what we did was we pulled the tube back, we put the PEEP up, and we repeated an ultrasound. And really what we were able to do is establish pleura with really a B profile, the C profile converting to a B profile. So that to me would demonstrate an element of lung recruitability, which favors a diagnosis of atelectasis as opposed to just pure consolidation. So I'm just giving you an example of how you might be able to differentiate the two. But classically, if you look at bronchograms, these bronchograms appear and disappear with inspiration, expiration. So you can see lung tissue just moving with inspiration, moving up. But these bronchograms, some of them appear and disappear, some remain because there's air trapped. On the other hand, when you talk about dynamic air bronchograms, they tend to move in and out of the bronchial and the alveolar interstitial space and the alveoli. Uh, Naturally, from our perspective, if you've got fluid in the bronchial tree which is entering into the alveoli, and if you look at my hand, it basically enters and disappears, and it moves like what I call as a caterpillar. I like to call this caterpillar sign. It's not been described in the literature, but this is classically how dynamic air bronchograms appear. They tend to move in and out. Just be very cautious. A lot of people get confused because in inspiration and expiration, static air bronchograms may appear and disappear, but they remain in the same place. So you can see the static air bronchogram over here appearing and disappearing with inspiration, expiration. And really it's because you've got air that's a little bit trapped over here that is probably reflecting at a slight angle. Now, when you inspire, this air becomes more prominent. When you expire, it becomes less prominent, but it's not moving in and out. So this is still a static air bronchogram, though it appears and disappears. It has to move in and out of the bronchial tree to actually be called a dynamic air bronchogram. Now, as I said, a dynamic air bronchogram is highly sensitive for the diagnosis of pneumonia. Now, what about atelectasis? Well, when we talk about atelectasis is really, it's a collapse of the alveolar space. And atelectasis may be due to a variety of different reasons. So you might have fluid in the lung, which is causing lung to be compressed. And this is classically an example of what is pleural effusion. The pleural effusion is causing compression of the lung. And because of that, you've got what is a tissue-like appearance with static air bronchograms. This is compressive atelectasis for you. Because you have fluid, which is a good medium for sound waves to travel, you can also see spine at the back. And classically, when you have large effusions, you see what is called a spine sign. This is compressive atelectasis. Non-compressive atelectasis can present because you've lost aeration of a particular lobe of the lung completely. Now, that may be because you have got no air coming in because you've got severe exudate blocking the lungs. And this is really important because really consolidation and atelectasis may coexist. So you may have a pneumonia with a presentation where you've got so much exudate that air can't actually enter the lungs. Now, naturally, if it doesn't enter the distal alveoli, you're not going to see the pleural margin. And if you don't see the pleural margin with a kind of a tissue-like sign, then this could be an atelectasis. It could also be a consolidation at the coexistent, and differentiating them can be incredibly difficult. The question is really, why would you want to differentiate them? And the answer is because there may be an element of recruitability in this lung, especially if this baby is ventilated, that might mean that you can use higher pressures to recruit an area of lung that's atelectatic. Alternatively, you might have a tube that's blocking, which you might need to pull back because it's down the right main bronchus. Or you might have exudate that can be moved by physiotherapy, as you would see with extensive pneumonias or with significant lung disease, as you see in chronic lung disease. Good amounts of physiotherapy may allow aeration of the lung, expansion of this particular region, which then really allows, from your perspective, better aeration of the lung and an improvement in ventilation. Now, this is just another example of static air bronchograms that you can see over here. This is also atelectasis for you. You can't see the pleura at this particular point. There is a large area of hepatization and a lot of static air bronchograms at this particular point. There is also an ipsilateral area of pleural abnormality that is actually consolidation. So they can coexist. This is the concept of dual pathology. Again, it has been said that you do not see, if you have dynamic air bronchograms, this favors mnemonic kind of a consolidation. Now, I'm just giving you an example here. So on the left-hand side, you've got what is classically what is a consolidation with dynamic air bronchograms, the caterpillar sign, as I call it, with air moving in and out. Now, this is an area of the lung on the right side. This is the diaphragm that you can see over here. This is the liver. And really what you're unable to kind of get a good feel of is the pleural margin because you have significant lung atelectasis. Now, this is lung atelectasis over here, but this is all consolidated lung at the bottom over here. And what you can see here is you can see dynamic air bronchograms. You can see air bronchograms moving in and out like a caterpillar. So this kind of concept that you can't see dynamic air bronchograms with atelectasis, it's actually flawed. And it's flawed because consolidation and atelectasis may coexist. I hope I'm answering a lot of the questions of both my old and new group, who are with us today, because really from our example, uh, I think a lot of people tend to kind of assume that just because you can't see dynamic air bronchograms, really this is not a consolidation. This might not be a mnemonic kind of a clinical presentation. Actually, they can both coexist. And this may be lung that actually is atelectatic because you've got a significant amount of exudate that's actually blocking this area of the lung. Now, this is a baby who might, if he's tubed and ventilated and stuck on the ventilator on high settings, benefit from physiotherapy, benefit from good positioning, suction. So really, there are therapeutic implications to be able to make this diagnosis. And sometimes it's just very difficult. So this is just an example. This is what I would say is a longitudinal scan. So normally we scan babies. We tend to do what I would call as scanning at right angles to the ribs. But scans in the intercostal space, and this is a classical scan in the intercostal space, which is why you really can't see the bat wing sign. But what you've got is a pleural effusion over here with a little bit of compressive lung atelectasis. Now, you've got this margin over here of, I would say, what I think is probably visceral pleura, parietal pleura separated by the fluid. But a real question is this atelectasis or is this a fractal sign? These are definitely static air bronchograms. And it can be very, very, very difficult to differentiate this. And really, your clinical correlation in this particular situation is key. Because if you've got a baby who's unwell, looks toxic, has a high CRP, you've cultured something from the ET secretions, then I think irrespective, you are going to cover this baby with antibiotics. And that's where I'd say try not to be too much of a pedant when it comes to it. I think the important thing from your perspective is recognizing and describing the pathology as you can see it when you report it. Now, the clinical course, serial lung ultrasound, and how the baby progresses will eventually give you that answer. Because actually, if this was a significant effusion causing compressive atelectasis and you tapped it and you got pus, then really, from our perspective, this would favor a mnemonic kind of a presentation with empyema. On the other hand, if this kind of effusion is transudative, and actually you found that this area of lung was recruited just by increasing pressure after about an hour, then actually mnemonic consolidations wouldn't necessarily improve that quickly. So again, what I would say is what is very important here is how you approach the clinical course. A very, I would say, uh, how should I put it, polite way of trying to kind of talk about lung ultrasound and Dopplers uh, to kind of differentiate mnemonic kind of consolidation from consolidation atelectasis is applying Doppler to see what the blood vessel distribution might look like in an area of tissue hepatization. Can I just say that in the literature for neonates, it's been described by different authors in different ways. So some people tend to want to describe uh, lung atelectasis uh, as non-aerated without any areas of blood flow. Again, what I would say is that's incredibly flawed. This is an area of what is lung atelectasis where you can actually see blood vessels. And what I would say is the risk in this kind of situation of saying that because I can't see any blood flow in this area, uh, this is atelectasis, uh, is risky. And the reason for that is I would say I've seen lung atelectasis with blood vessels at the base of the lung, which we've been able to recruit quite quickly. Now, that's where I would say clinical correlation is key. Now, this obviously from our perspective is an area that looks very much like a fractal sign. Increased vascularity in this particular area would favor a mnemonic kind of a presentation. I'm just giving you an example over here of a baby who, again, we've done a lung ultrasound in. And really what you can see in this particular situation is pleura that's established in inspiration that collapses in expiration. Now, the question is this atelectasis in expiration with static air bronchograms that you can see, or is this a fractal sign? And it's a really difficult one for me. My gut feeling is it's a bit of both. But really, what you can see is blood vessels in this particular region when you put Doppler on it. Now, as you put Doppler on it, with the blood vessels, I think all of us would agree that in this particular situation, if this was an acute kind of a clinical presentation in a baby who has a high CRP or looks unwell, we would definitely be covering this baby with antibiotics. So irrespective, I would say try not to confuse yourself too much. Look at the basics, describe what you can see. And again, it's the clinical course that this takes in response to antibiotics in this focal region that's really going to give you a feel of whether or not this eventually is an area of fractal sign or a mnemonic kind of a consolidation versus an area of atelectasis with static air bronchograms. So give yourself a little bit of time, do serial ultrasounds of the same region, and really follow it up. What is important is that you really do a comprehensive scan of your images to try, from your perspective, to be able to make a determination of what pathology you're seeing. I mean, just to conclude, what I'd say is that it can be very challenging differentiating consolidation from atelectasis. Now, this is a classical example of where both of them can coexist. So you've got no visible pleural line. That's diaphragm that you can see over here. It's an area of what looks like hepatization. One of the classical things that I would say we describe with atelectasis is the fact that it tends, from our perspective, to take a very geometrical kind of a shape. And if you look at this, it's very triangular, as opposed to consolidation, which could be irregular. And this is just a classical example of the shape that you have, which is atelectasis, but consolidation below. And you can actually see both static and dynamic air bronchograms coming in and out. This is dual pathology for you. So you must clinically correlate in these circumstances. Now, I'm going to take a little bit of a break, and then what we're going to do is we're going to talk about a few cases. So I'd like to invite questions from the audience. I'm going to enable chat for all of you just while we take a break. And then what we're going to do is we're going to look at a few cases. So I'm just going to stop share. So I'm just enabling chat for all of you. So you can either raise your hands or you can put chats. So any questions? Okay. So I've got Ashraf. Go, Dr. Ashraf, go for it.
Thank you, Dr. Alok, for the nice talk. I think the main difference between athletics and consolidation, two signs. The one, border of both of them, in the
Yeah.
athletics will be clear border, in the consolidation will be a regular border.
Yeah.
And the missing or absent shred signs. Otherwise, all signs, both of them you can get it. These two signs, you can never both of them in the same area unless there is constitutional collapse.
Yeah. Fair point. I would say that the kind of geometric appearance of the lung would favor atelectasis. I think what I'd say is that if you have dynamic air bronchograms with a tissue-like sign, that would tend to favor, I would say, consolidation or a mnemonic kind of a presentation. Shred sign again would favor a mnemonic kind of presentation. I've just shown you a few examples of how difficult it might be. I think for me, a really important take-home message is describe what you can see, clinically correlate. Think about the reason why that might be the case. Think about your
Yes.
ability to be able to recruit that area of lung. It might be a simple thing, that lung position that changes what the appearance of the lung looks like. And I think for certain conditions, I think if there's concern with regards to a mnemonic presentation, really what we should be doing is comprehensive scans. The anterolateral scans limited to the front and the lateral regions really might miss significant areas of consolidation atelectasis, especially for babies who are nursed, ventilated, supine. So I've got
Yes.
a few more people who want to ask some questions. Just unmuting, allowing all of you to be able to talk. So go for it. Anybody else?
Hi, hello. Can I ask a question, please?
Yes, please, Arif. Yeah.
Hi, thank you for this nice lecture. I had two questions, which, as you said, that in case of deep ET tube or the bronchial blockage by the X-ray, by the secretions or whatsoever, there will be a localization of the lung-like picture. So in case if
Yeah.
it is a deep tube is deep in the right main bronchus most likely, so
Yeah.
the hepatization will be seen in the other lung or in the same lung where the tube is deep. And the other question, second question, if you could just briefly explain the difference between the fractal sign and the shred sign, please. Thank
They're
you.
the same. Fractal sign and shred sign are essentially two different terminologies described by different
Mhm.
authors which represent the same thing. So
Okay,
in
okay.
essence, what you have is you have an area of consolidation that has very irregular borders. It's
Mhm,
because lung has been destroyed by a necrotic process of some kind. It can be
mhm,
seen with meconium aspiration, pulmonary hemorrhage, can be seen in babies who have evolving chronic lung disease. But if you have it and it's new and it's acute and it's associated with raised inflammatory markers, then really, I think what you should be worried about is the potential that this baby might have an infection. I
yeah,
think what is also very important is just remember, often with extreme preterms or babies who might have secondary infection, you might be doing a lung ultrasound today for a baby who's had an infection about 10 days back treated with antibiotics. Now, that baby may still have a fractal sign with a consolidation, but maybe the antibiotics have treated the baby and the baby has evidence of thickened pleura with what looks like a B profile. Now, if that's an extreme prem who's 34 weeks of gestation, who's on Optiflow, really what you're looking at is chronic lung disease, but with a baby who might have had a pneumonia in the past. That's dual pathology. So
yeah,
I can't emphasize enough that a fractal sign and its mere present is not always correlative of just pneumonia or infection.
yeah.
Uh, I think what I'd say is the differentials include clinical correlation, if you have this at birth in a baby who has meconium with patchy consolidation, with a normal CRP, with a baby who's rapidly improving, then really this could just be meconium aspiration as opposed to an infective process.
Right.
Does that help?
Yeah.
Your
Thank you.
first question, I've lost it. Your first question, I
So
missed.
I
Yeah,
was, the tissue hepatization in
yeah,
case of less aeration.
yeah.
In if the tube is deep in the right main bronchus, most likely it will be. So the hepatization will be seen in the other parts of other lung because that will be less
No, no,
aerated
no, no.
on
So
the same
okay,
lung.
let me share my screen with you again. Just take me a second. Can you see my screen? Is it visible?
Yeah.
Okay, so this is classically the right side of the lung that you see on the left side. Okay,
Okay. Yeah.
now the tube is down the right main bronchus. Because it's down the right
Okay.
main bronchus, this is the right upper lobe on the ipsilateral side that you've lost. You have airspace
Okay.
shadowing. Uh,
Right.
completely opacified lung because air cannot enter this area because the
Mhm.
bronchus is completely obstructed. So if you have, a tube down the right main bronchus, really just what you'd see in this particular situation is hepatization, loss of tissue. I mean, this is an element of consolidation with atelectasis, I would say both. There's an
All
element of
right.
reversibility. We pull the tube back, and I'll show you images of a similar kind of a baby where we were able to recruit lung, but it didn't disappear completely. So
Mhm.
really, that's why I would say there's potential that you might have both pathologies. And being too pedantic about is this consolidation or collapse can, sometimes just unnecessarily cloud your opinions. Uh, yep. So any other questions?
Thank you. Thank you. Very much.
Mm. Good evening. Just look, I have one question, please, or two questions.
Yeah.
Thank you very much for your presentation, as usual, shining. So just my first question, just during our experience when we are doing the lung ultrasound, so some baby you did the M mode for some region of like a profile,
Yeah.
and you find some barcode sign on the M profile, on the M mode. And when we did or we control it by X-ray, X-ray doesn't show any significant air leak. Did this happen with you during your experience?
Yes, there are multiple reasons for that. So the first reason for that is, can you see my hand?
Yeah,
So if you do not have adequate gel on the
yeah,
interface between the skin of the baby and the probe, then really what is going to happen is you're not going to have an interface which allows transmission of sound waves. And that will give you a classical barcode sign. Also remember that when you go into the left upper and the right upper regions, that is classically, I would say, R1 and L1, then because of the concavity of these areas, you can lose the interface. So you might find that actually the lower half is in contact and the upper half isn't. Again, similar with the axilla, if you don't abduct the hand, you can lose interface and you might actually get a barcode sign. The
yeah,
other kind of differentials of this are classically what are described as the pseudo barcode sign. Now, pseudo kind of barcode sign can be seen in a variety of conditions where you're looking at the stomach. So if you're on the left side and you've got a
yeah,
very distended stomach, again, the way you differentiate that is by making sure that you cannot see ribs or a batwing sign. But the stomach on that left-hand side can give you a very classical barcode sign. There are at least 5 other causes. There is pseudo barcode sign, I would say, lung point that's been described as well. So those are just a few of the reasons why it might be the case. In my experience, it's usually loss of interface.
Okay, thank you. The second question, so some baby also, when we also, for example, when you clinical correlate between your ultrasound finding and the clinical status of the baby and the paraclinical with lab test. For example, on POCUS, when you sometimes we found AB profile, some areas mainly posterior I'm talking about RC, R4, LC, R4. You have B profile, some subpleural consolidation, small one, and you have high CRP with pneumonia. But we don't have this typical picture of pneumonia with consolidation collapse finding on ultrasound. Is this happening with you also in your experience?
I'm going to talk about it. I'm going to talk about it just in the last 20 minutes when we look at cases. So yes, and really what you've got to do is clinically correlate. Those consolidations could be infection. The absence of a fractal or a shred sign does not exclude a mnemonic kind of a clinical presentation. I mean, I'm just giving you an example. I've lost a baby in 24 hours with evolution of what is a right-sided mnemonic consolidation, where we basically cultured Pseudomonas from the ET secretions. The CRPs actually went up, very rapidly, and there was no shred sign. It was a right-sided focal consolidation. So it's very much possible, and really that's why clinical correlation is very, very important.
Okay. Thank you very much.
So I have a question from Anna Kasani. Is lung ultrasound limited in detecting deeper areas of consolidation? It's a beautiful question. And Anna, what I'd like you to do is have a look at my screen. So really, when we talk about deeper consolidation, there's a real argument and a debate about whether a deeper consolidation really from our perspective exists, because actually when we define consolidation on lung ultrasound, we always say that the pleura has to be abnormal. Everything, all pathology that we see on lung ultrasound, actually from our perspective, has to arise from the pleural line. And this is a classical example of consolidation that has taken its origin from the pleural line that you see over here. Now, there's no fractal sign. If this is a baby with a high CRP, this could still be a mnemonic kind of a consolidation. Alternatively, it might just be a consolidation that you see because you've got alveolar tree obstruction as with alveolar interstitial disease. Now, this is naturally an adult. But the reason I'm raising this is because you might have consolidations in the deeper areas of the lung that don't impact the pleural line. Now, by definition, you will not see these areas on ultrasound. But if you do a comprehensive ultrasound, you may be able to see these areas. And that's why it's really important that you do all the regions if you're worried about mnemonic consolidation. That would be, we use a nomenclature that standardizes R1 to R6, L1 to L6, a 12 region method. And you must perform that, because really, even with those, some element of pleural involvement, even with the deeper consolidations, may be seen. Does that help? Okay, I've got a question from Praveen. Praveen, do you want to unmute yourself?
Yeah, Alok, my son is here on the TV, so sorry if there's
Don't
some
worry, it's
background
okay.
noise.
Yeah.
So we have this occasional ex preterm, who is now 32, 33 weeks old, has a respiratory deterioration, some rise in CRP, neither here nor there. And then you have a chest X-ray, which is not very clear. It could be some evolving BPD, atelectatic areas, but could it also be a viral consolidation? Usually it's non-lobar. So how do you differentiate these two pictures on a lung ultrasound?
I'm trying to understand the question. So viral pneumonia and bacterial pneumonia, you're saying differentiating?
Yeah, I mean, I'm trying to say that usually
I would say that it's very, very difficult to kind of say with absolute certainty that you can differentiate the two. I mean, with COVID, uh, especially in adults and children, you could see the full plethora of presentation with COVID that you would see with any bacterial pneumonia. I don't think at the moment we have any signs that are sensitive enough to be able to differentiate this on ultrasound alone. It would be clinical correlation. A classic example from my perspective would be if you've got a baby who's got risk of RSV, coming back to the kind of PICU. Now, you could see a shred sign in that particular situation because this baby has had previous chronic lung disease with significant necrotizing kind of damage to the lungs, but has now had a superimposed hit with RSV. So, you know, I'm not sure that you can use lung ultrasound alone. You'll have to clinically correlate. Now, in that situation, if you came back positive for testing for RSV, on the antigen and everything else was negative with a CRP that's not very high, then really you could consider that to be RSV pneumonia. Do you get what I'm saying?
Yeah, I get you, Alok. What I was trying to ask was that how do you differentiate between atelectasis from BPD, evolving BPD, and atelectasis with a new consolidation?
Okay, you need to do serial lung ultrasound.
Okay.
And really,
Okay.
a very good talk that was given by Almedina kind of says that we know that lung disease starts evolving very much before we start defining BPD as an abnormal lung appearance at 28 days with an oxygen requirement. So really, if you start doing serial lung ultrasound and you start looking at lung ultrasound scores in that particular situation, it helps you predict BPD as an outcome, but the morphological appearance of the lung on ultrasound, if you're following it up, and a classical example is if you have thick pleura with a B profile and you've been doing weekly scans, and suddenly this baby deteriorates with an increasing FiO2, necessitating ventilation, with the appearance of consolidation in an area where you previously did not see consolidation, uh, with bloods, with a rising CRP, then that would favor an infective process of some kind. You would then have to use your microbiology and markers to make a diagnosis. But that new consolidation appearing in the context of lungs, which previously were just wet, would be abnormal. And that would favor me thinking that this is possibly pneumonia superimposed on BPD. Now, if that then evolves into a fractal sign after 48 hours, that confirms my suspicions. The CRP rises, that confirms my suspicions. That favors, the potential that this could be a bacterial pneumonia as opposed to a viral pneumonia. If my CRP is 200, say, for example, and we've recently seen a baby like that. On the other hand, we also know that adenovirus can give you very high CRPs in babies. So I'd stay away from trying to use lung ultrasound in isolation. I would look at serial lung ultrasound, the appearance of new areas of consolidation, sudden appearance of fractal sign. On the other hand, if you've treated a pneumonia and you've given 10 days of antibiotics and you had a fractal sign, and that actually reduces in its kind of appearance, its density, it looks less in terms of the measurements, then that's something that's responding to antibiotics. That would be taken to me as sign that that was a mnemonic consolidation, which is now responding. So serial lung ultrasound can help.
Excellent example. Thanks, Alok. Thank you.
Any other questions? Okay, I'm just very quickly going to look at a few cases with you, just to kind of give you a little bit of a feel of, again, the importance of why we should not be too, I would say, obsessed and kind of trying to differentiate atelectasis from consolidation. I think the key from our perspective is clinical correlation. It's thinking about why this baby has the lung ultrasound appearance he has at this particular point of time. And it's to emphasize that a chest X-ray is looking at the lungs at one point of time. So is the lung ultrasound. So really, from our perspective, if you're looking at a lung ultrasound today, and you can see a consolidation, as you can see here, you have a high CRP, you start antibiotics and it responds, then this would, from my perspective, favor a consolidation. On the other hand, if this was an area that's just appeared because you have a baby who has suddenly deteriorated with the rising oxygen requirement, and you have a very geometrical appearance to that particular area with the loss of pleura, then really that might favor a lung atelectasis. Maneuvers to try and open that area of the lung up, increasing pressure, increasing or doing physiotherapy. In some situations, we've used DNAs in some babies to open up that particular lobe. Now, if that suddenly disappears after or improves to a kind of a B or an A profile, then that would favor atelectasis. I want to keep it simple. My diagnosis of a consolidation is made by a pleural abnormality. This could be reduced sliding, it could be irregularity, it could be thickening. The presence of what looks like hepatization of the lung, as you can see in this particular region over here. the presence or absence of air or fluid bronchograms, depending on the reason for the consolidation. Is this an infective process producing a lot of exudate, or is this just a situation where we've got a tube obstructing a bronchus so that air that's already there can't move out? The presence or absence of a shred sign or the lung pulse neither excludes nor, I would say, is pathognomonic of the diagnosis of consolidation. What is important from our perspective is the sensitivity and the specificity of diagnosis go up. As Dr. Ashraf has said, if you see a shred sign, it tends to favor consolidation. The presence of a shred sign in the presence of certain biochemical markers tends to favor the possibility that there's an ongoing infective process, but really it can be seen with meconium aspiration, pulmonary hemorrhage. Lung pulse can be seen in both consolidation and atelectasis, and its presence or absence does not necessarily differentiate either of these two. This is really important. So just with that in mind, I'm just going to talk very quickly about the different kinds of consolidation. Now, we talked a lot about translobar consolidation because we commonly see it. And examples of translobar consolidation would be a congenital pneumonia affecting one of the lobes of the lung, an infective pneumonia secondary to ventilation-acquired pneumonia, which again might affect a particular lobe of the lung. On the other hand, we might have what are described very classically by Dr. or Professor Jing Liu in his work on consolidation as focal or occult pneumonias. Now, a focal pneumonia might be a segmental collapse of the right upper lobe, which is seen because the tube is slightly low. On the other hand, you might have an occult, I would say, area of consolidation or atelectasis, which is seen because it's so small, it cannot be picked up by X-ray. And then really we have a description of what we call as subpleural consolidations that are classically described with RDS, which take place because of hyaline membrane disease. So really, this is an example of a complete loss of the right upper lobe because the tube's down the right main bronchus. So this is really, it's a translobar or lobar pneumonia because you're losing a whole lobe. Again, this is an example of a lobar kind of a pneumonia, just highlights the tissue sign. On the other hand, what I would say is if you look at these areas, these are very focal areas of consolidation. Now, this is really what I would say is a very kind of a focal area with a pleural line that's visible with some static air bronchograms seen in real time over here, very similar kind of an appearance. Now there's an element of compression over here. So there is atelectasis, but there's consolidation as well. And there's static air bronchograms. Now, whether you call this a consolidation, whether there's an element of atelectasis, whether there's an element of both, really from my perspective, I wouldn't get too wound up about it because the question is, how am I going to manage this? And that will depend on the clinical presentation of the child. When you talk about RDS, it's classically diffuse. It's not lobar. And the reason for that is you have a diffuse presentation because of the formation of a hyaline membrane because of surfactant deficiency. Now, again, what you're seeing over here is subpleural consolidations, a lot of static air bronchograms with these areas of what are subpleural, very small consolidations. This is a classical snowflake sign for you. So the important distinction that I want to make over here is that your description of consolidation varies based on the underlying etiology. So my advice to you is describe what you can see. Always try and make out whether you can see an abnormality of the pleura, whether it fits with tissue hepatization or not. An element of immediate reversibility usually favors atelectasis. Now, this is atelectasis with consolidation for you. And this is classical RDS, and this is severe RDS, as you can see over here in this particular image. Now, the options for me to be able to open up this area of lung is I could give this baby surfactant, which will reduce surface tension of the alveoli, open them up, allow better aeration. And what you might find is that these areas of subpleural consolidation persist, but this area that looks tissue-like might actually be recruited. So you might have a bit of both, consolidation with atelectasis in this particular point. And that's why I would say, try not to get too hung up about it. Think about what you might be able to do from a therapeutic perspective to really manage this baby. And the management here would be surfactant if you've not already given it, possibly a higher PEEP, maybe higher pressures. If this is the posterior part of the lung, you might actually want to try prone ventilation. So really, that's the importance of trying to differentiate and trying to make a diagnosis. Again, very important take-home message. Please do not confuse a translobar consolidation with the thymus. It's very commonly done. This is just another example of what is a mnemonic consolidation. Now, this is an X-ray, which didn't really give us a feel for any particular area of consolidation. Uh, it just had a kind of a diffuse kind of a ground glass appearance. But really, what you see if you do the lung ultrasound is this occult area of consolidation with static air bronchograms. Now, really, this could be mnemonic if it's a baby who's got a high CRP, who is deteriorating. It might be a baby who's got meconium aspiration. If this baby has significant meconium in the background with patchy kind of consolidation seen in different areas. So clinical correlation is absolutely key. I've shown you this image of shred sign, severe shred sign. We've talked about bronchograms. Just again, just a few things that I'd like to show you. So when we talk about the diagnosis of atelectasis using neonatal lung ultrasound is definitely more sensitive because there are areas of atelectasis that you will not find visible on chest X-ray. And this is very well exemplified in work that's been done by Jing Liu, a study on 80 neonates, where they detected atelectasis with a sensitivity of 100% in 80 neonates. The chest X-ray and clinical presentation alone missed atelectasis in 20 of these babies. So, sensitivity, specificity much higher when you're using lung ultrasound. At the end of the day, what is very, very important from our perspective is pattern recognition. And again, these are just different kinds of atelectasis. Again, you can't see an established pleural line. It's very geometrical in its appearance when you look at it. This is liver, there's diaphragm. Now, consolidation tends to be a little bit irregular. Now, this is an area of consolidation for you that you can see over here. But this is atelectasis, again, very geometrical. But one of the classical signs of atelectasis that Jing Liu has described, and that I have not found anywhere else in the literature, is what is described as linear air bronchograms. And I have seen this very commonly in babies with chronic lung disease or babies who ventilated who developed acute atelectasis. So this is classically a picture, and I'm going to give and pay credits to Jing Liu, of a baby who's got compressive atelectasis with a pleural effusion. You've got pleura that's visceral, pleura that's parietal. You cannot see sliding because it's naturally pleura that's separated. But more importantly, you can see lung pulse. Now, you've got this area of consolidation that appears and disappears. This is just a large static air bronchogram. Again, you've got static air bronchograms here, but what you've got is these linear static air bronchograms that remain constant. Some people find this to be highly correlative of acute atelectasis, and the presence of these horizontal lines actually is supposed to demonstrate recruitable lung disease, so that if this baby is intubated, ventilated, putting pressures up, trying to position and open this lung, this pattern, as it's described, actually demonstrates lung recruitability. This is just another example of it that you can see. Again, it's just an example of people say you can't see dynamic air bronchograms with atelectasis. Actually, that's not true. Air can be trapped. And if you've had acute atelectasis in a baby, really you might find air that's trapped and just about enough aeration to allow air to kind of move in and out of the alveolar spaces. Now, this is a large lobar area of what I think is atelectasis. I cannot see any pleural margin, but I can't see air move in and out. Now, again, clinical correlation is key because if this is a baby who has a high CRP, it might be acute atelectasis in a baby who has a mnemonic kind of a presentation that's evolving, where there's so much exudate that we've kind of lost lung on that particular area because it can't aerate. And then you have these linear air bronchograms that are there. So this might be a mnemonic presentation in a baby, and it may well be recruitable. So there's no harm in trying to see if you can recruit that lung with ventilation strategies. You must always remember that you can have dual pathology. So you might have RDS with an infective process. Now, if you have RDS with an infective process, who says you might not be able to find subpleural consolidations with a fractal sign? They might both be there. So you might have secondary surfactant inactivation, which gives you subpleural consolidations. I've seen that in babies with quite severe meconium aspiration syndrome. with a fractal sign. Again, there was significant meconium in the history. This baby was just born. So your clinical correlation is quite key. And I think, this is where I would say that consolidation with atelectasis can coexist, as you can see over here. And this might be recruitable lung, whether you give surfactant or you try to recruit that lung with high pressures. There's an element there. And then it might be so confusing that you might think there's a fractal sign there. Now, my question is really, if you're unsure, uh, lung recruitment with increased pressures might help. But if you're unsure, you're going to cover with antibiotics anyway. So don't get too hung up. With regards to Dopplers again, I'd just be very careful. You can see Doppler appearances that are quite similar. And this is just an example of atelectasis where you can see Doppler appearances. So this is atelectatic lung for you. There's no pleura visible. It's very hepatized. There's some static air bronchograms. But actually, when you look at the blood vessels, and this is from Jing Liu's protocol for lung guidelines, there is classically, from your perspective, a lot of lung vessels that are visible. Now, it may well be that there's consolidation here with an infective process where you have hyperemia. Actually, in the area of atelectasis, in this region here, I can't see any vascular region. There are no vessels. So like I said, pathology may be dual. It may be atelectasis with consolidation. So can you see classically how the atelectatic area, as you see it, doesn't actually have blood vessels in it? Sorry, I'm just going to show it to you again. It's a very good example. Again, just another example. So I'm going to throw this out to the audience, guys. There are two images over here. So we're going to talk about the upper image. Dr. Ashraf, I'm going to invite you to say what you think of the upper image. It's L1. Background is a term baby. And there's meconium. You might not have. Anybody want to have a go? Nobody brave enough? Anna? You want to have a go? What do you think? Atelectasis or consolidation? The upper image.
I see the pleural line that is not regular, it's broken, and thickness,
Yep.
and tissue sign.
Yep.
I really don't see a shred sign, I think.
Very good.
It's very linear, the borders. So maybe atelectasis. I think I can see a little of fluid.
Yep. So again, it's just to highlight how difficult it can be in trying to make the diagnosis. What about below? What about the image below, Anna?
It's a worst image because the pleura is worse,
Yep.
very disrupted and irregular. And I was more inclined to think it could have some infection behind this image.
Yep.
Because of the irregularity of the image.
Absolutely right. Now, there's a thing that I do when I'm confused, and this is something that all my new batches and my old batches will it's called mental modeling. So if I'm confused in this particular situation, I do my clinical correlation. I try to kind of make a mental model of what I think the clinical course in the history is. And really, if I kind of said to you at this particular point that this is a baby at the bottom with a CRP that's gone up to 90, who's got Pseudomonas in his secretions, and this is the right upper lobe, then really you'd favor a diagnosis of pneumonia. On the other hand, if in this particular situation the CRP was normal, and this was a tube down the right main bronchus, we pulled it back and repeated an ultrasound, and you were able to recruit significant amount of lung to a point where it starts appearing like lung appearance over here, which is pretty much well aerated, then really you might say that this is atelectasis. I think that's where I would say that what you can do if you're confused is look at a therapeutic intervention that might help, but more importantly, phone a friend, get another person to have a look at it, get two people to have a look at it and try to make a diagnosis. And we call that joint mental modeling. So just another good example of how difficult it can be. This is an example of dual pathology. So if you look at the top of the lung, normal aerated lung at the top, now shred sign, and actually atelectasis at the bottom with a syndemonic effusion. So you can see everything, normal aerated lung, classical shred sign, syndemonic effusion with atelectasis. Now, I think everybody would agree, be surprised if this is not an infective process, and this is basically a child with mnemonic kind of presentation. But you've got all pathologies here visible in one field, so really they can coexist. Again, just a thought, if you have dynamic air bronchograms moving in and out, the sensitivity and the specificity for a diagnosis of a mnemonic kind of a presentation is quite high. So it tends to favor pneumonia, but as I've demonstrated to you at the margins where both things exist, you might actually find that you can see dynamic bronchograms even with atelectasis. And this is a classical example again, where you can see on the left-hand side, dynamic air bronchograms, but you can also see what is consolidation at the bottom with atelectasis at the top with air moving in and out. So just be very careful. I would say that the presence of complete atelectasis, as you can see over here, this complete atelectasis of this lobe, my experience when I put Dopplers in this region is I've never found blood vessels. You may find blood vessels below in the area of consolidation, especially if there's a healing pneumonia with reactive hyperemia. You may not. So the presence or absence of blood vessels per se to kind of differentiate atelectasis from consolidation needs to be dealt with very carefully because they can be seen in both. That ends my talk. Any final questions? Feel free to unmute yourself. I've given all of you the ability to do that. So I have a question from how often should we do serial ultrasound if we're suspecting a mnemonic consolidation? That's a really good question. So I can tell you for a fact that with meconium, there's at least one study that shows that the consolidations can persist up to 4 weeks. Now, it's a very small study done on 4 babies over a period of 4 weeks. Mnemonic consolidations, really, the changes that you see on them and the fractal sign, it can take weeks to improve. A lot of it depends on, again, response to antibiotics. In the UK, I hardly used to see a lot of fractal sign, but having come to the UAE and in India, we get a lot of gram-negative sepsis and we see a lot of it, and it can persist for a significant period of time. So that, I hope that answers that particular question. It can be weeks. In terms of kind of how often to do the scan, it really depends on what questions you're asking. The question I'm asking is, my baby's getting better, clinically responding to antibiotics. Do I need to? Very similar to, do I need to do the chest X-ray? If it's not, if there's something that I want a new question answered, my baby's getting worse, there are, at least Pradeep presented last week, they've been following up consolidations and treatment with antibiotics, and they've developed a consolidation index to kind of look at and count the number of consolidations, as well as measure size and response to treatment with antibiotics. It's still unpublished data, but they'll be publishing it soon. So, it'll be interesting to see how that develops. I'm really grateful to everybody. I'm going to end here. Thank you all for your patience. It was a long talk. I hope I've tried to answer some of the controversies. Again, for those of you who are with us on the course, feel free to put it on the WhatsApp group. We'll be sharing a lot of cases with you, and we have a lot of practice coming on Thursday. Lots of cases for you to practice on, both you to present and for you to practice on. So thank you, everybody. Have a good day.
Thank you very much, Alok. Thanks a lot.
Thank you, Alok.
Thanks, Alok.
Thank you.
God bless you all. Have a good day.